So we move to the second case from Bicêtre, Paris. So this is a 65-year-old male. He's right-handed. He got in January 2018. He was found unconscious in the subway truck. This is the CT scan at the time he was found unconscious, which is clearly demonstrating a huge temporal hemorrhage. At that time, the patient got a shunt, and he has a cranial control of the intracranial blood pressure. And we did an angiogram. This is the different steps of the angiogram, looking at the vertebral. There is quite a bit of mass effect, as you can see here, and we can already see the small AVM that is clearly shown on the angiogram in the medial part of the temporal lobe. This is a later phase, demonstrating the venous drainage, going that way to reach finally the straight sinus. The arterial pedicles are definitely coming from the P2 portion of the PCA. So this is a clinical follow-up. Day one, the hematoma was evacuated. He got a hemicrania for decompression, a flap. D5, he was extubated, and clinically they presented with an hemiparesis and aphasia. Then he was discharged from the neurointensive care unit 30 days after the onset with an MRS-3. After 6 months of clinical follow-up, physiotherapy for 2 months, he had a total recovery of right hemiparesis, a minor aphasia, right hemianopia, and he was able to walk by himself, MRS-2, which is a pretty good result compared to what he had at the beginning. So this is a CT scan 6 months later, showing the scar of the bleeding in the temporal area. And this is a new angiogram. There was quite a bit of mass effect at the very first time when we did the diagnostic angiogram. Now this is later, 6 months after the onset. We clearly recognize again the AVM. We have a very good view of the venous drainage. As you can see here, these are the different phases of the angiogram. This is a close-up view, starting to show the origin of the foot of the vein and the nourishing pedicles coming from the posterior circulation. Pre-treatment plus 6 months. So this is the 3D. Again, when you look at the 3D, you have a full understanding of the nidus. You can also recognize, you will see a schematic drawing showing the different parts that are interesting, which is the vessels and the venous drainage. So you have the venous drainage clearly visible on these highlighted pictures. This is the same. So this is a schematic drawing, a kind of summary of the concern. Arterial pedicles, 1 and 2, and venous drainage. Arterial pedicle and venous drainage. So we decided to get all the weapons to treat this malformation, to have a double approach, one from the artery and one from the vein. So there is an arterial access, the femoral sheath 6F. The guiding catheter is going to be the Sophia EX, which is the new stiff Sophia. The microcatheter is an Apollo 1.5. with 1.5 centimeter, because this is not more segment of security that we have according to the understanding of the microanatomy. And the micro guide wire is a hybrid 008 from that. The jugular approach, you have the 6 French sheet, which is a direct stick of the jugular vein. We always use the jugular vein because in case you need to leave the catheter inside the venous system, you just cut it at the neck and you leave the catheter. The guiding catheter is a Micro Fargo Max, through which we deliver a vertebral glide 4F, a long one. So otherwise, you cannot pass the Fargo Max, and it gives you the possibility to work. When you stick the neck, you can work at the level of the groin with the whole material, and you have a full access and a strong push using this system. So, okay. So this is the whole thing which has been prepared. For the time being, everything has been already done, the arterial and the jugular approach. And we are going to move to the live case. Hello.
Jacques, it's okay? Can you hear me?
Yes, perfectly. We hear you perfectly. It seems that you don't hear us.
Okay, I think you are hearing me. So probably you have on the screen the 3D. So the 3D, we have increased a lot the delay for the X-ray. We have 8-second delay for the X-ray, conversely to the dye injection, in order to nicely see the venous drainage. And we have colored in orange the feeder. It seems that the feeder, as you can see here, is through the posterior cerebral artery. And you have this posterior temporal branch, which is giving rise to the nidus, which is pretty short, as you can see. So this is why we have also prepared a venous access, direct stick of the jugular vein. So for the time being, we didn't navigate anything. We have Fargo Max in the right vert, and we have the Apollo ready to catheterize the left superior cerebral artery to have a nice view of the nidus, but we didn't do it for the time being. And we have also a jugular access with a 4 French vertebral curve, which is now placed in the straight sinus. And the aim, you can see here the origin of the basilar vein. As you can see here the angulation. But of course, you have to also look on the biplane to see in which direction you are going. So I have selected this view to catheterize the superior cerebral artery, to put in place the catheter. The lateral view, we can't reach this view because of the collision between the two C-arms, so it's more or less something which resembles to that. And afterwards, we will be managing the venous access. Okay?
This second arterial pedicle, isn't that one longer? The second arterial pedicle.
So now we let Laurent start in the case. Selective injection, it's not because you have the two approaches that you will be using the two, but at least you're ready to use it. If it happens that it's easy to do by the arterial way, we'll be only using the arterial way. If it's happened that it's not that easy, or if you cannot reach completely the nidus, because the goal is to get a complete occlusion, then we can finish with the venous approach. In this location, considering the anatomy of the venous output, it might be a little bit difficult to navigate retrogradely in the venous system. So we'll do it in case it's absolutely necessary. So at least we are in the condition where we can do the job in good condition to get a treatment of the patient and a complete cure, anatomically speaking. It's not an easy case just because of the anatomy. The segment of security, which is, the distal part of the arterial access compared to the entrance of the main pedicle, which is the posterior cerebral territory, is definitely short from here to here. It's not direct supply from this branch. There is another perforators from here. So it's a little bit less than 2 centimeters. So it doesn't give you too much option for the reflux. So in case we need more, we won't continue from the arterial side, and we will be switching to the venous side.
So Jacques, I have a question for you. Considering that you get good approach from both the arterial and venous side on this case, would you always start transarterially injecting, and then if you cannot close it, would you inject like transvenously?
The answer is potentially yes, but it's never always. Here, if the direct access to the venous system was looking very easy, we would probably start from the venous side. But it doesn't seem to be that easy. So we will see what we can do from the arterial side, and let's switch to the venous if we need it. Sometimes the venous access is straightforward, sometimes it's not that easy. So, if you can avoid doing it, you avoid it. It's just a question of anatomy and necessity. But at least you are ready to do it.
If you come from the venous system, or you plan primarily, would you consider putting a septal catheter on the arterial side?
The answer is no. We don't consider doing this because the navigation in the venous system in this case is going to be difficult, and to navigate with a septal is completely different.
Not in the venous system. To protect the arterial side, if you have a septal on the PCA, about where you have the tip there,
No.
as you're navigating in the vein, if it
No.
ruptures, you can inflate it. You can.
No, we don't think about, because to reflux from the venous side up to the nourishing pedicle, up to the origin of the PCA, you should inject blind, otherwise you have a full control. So we don't foresee having any trouble, even if we inject from the venous side, to have reflux up to the parent artery. We have a lot of experience with the venous injection, and it's extremely rare to not control the arterial output from the venous injection.
No, Jacques, I think, if I may, Alex, I think, is it advantageous to kind of obstruct the arterial flow when you're injecting retrograde through the vein to have better penetration, so not to have a competition from the antegrade arterial flow?
No, we don't think it's necessary. This is our experience.
Okay.
We have been doing that a long time ago, and it was not giving really a good difference in terms of entering or penetration of the liquid embolic material. As far as you get an occlusion of the venous system and you keep on pushing, you have a very straightforward full access to the nidus, and you have a good control of the potential reflux. If you feel more comfortable, you can put a balloon. This is your own choice, but this is not our choice.
But you are having this approach on venous because it's a unique vein, isn't it? If it
The
was
single
more than
vein.
one vein of drainage, you will not have this kind of approach by the vein.
No, I think you can split the treatment of the nidus of an AVM compartment by compartment. As far as you are dealing with the vein and its compartment, it doesn't make any difference. You can have multiple venous drainage and attack the nidus compartment by compartment according to the different veins. The problem is it's much more difficult because, venous access in 2 or 3 different veins to get access to the nidus, especially when it's a small nidus. It's a small nidus with not that much flow. The vein is not that much dilated. It's not that easy to navigate through. So, you have to compromise. If you have a big vein like that, you can put multiple things inside. If you have a small vein like that, it makes a big difference. We think that there is a chance to get the treatment of this AVM from the arterial side, but we are not sure, so we are ready to do it from the venous side if it's needed.
Jacques, are you still using the pressure cooker approach? Are you still putting some coils or not regularly in this location?
No, we use the old way of calling a pressure cooker, which was plug and push. It's a different name for the same thing. So, each time you use, something else and push and plug and push and pressure cooker, you have to add another catheter, you have to navigate twice. In some cases, it's not that difficult because the vein is big, but, what kind of pressure cooker technique are you going to do here? It's extremely difficult
with the
already to navigate with one single catheter inside. So, yes.
Is he talking?
So there is a small technical problem, which is impossibility to enter the wire in the hub due to the needle is using, which is not fitting perfectly to the hub of the catheter. So here is the problem. So maybe there is a concern at the level of the hub of the microcatheter. So it's a little bit difficult.
The hub of the Magic is just so much superior, This is the Apollo, correct?
Yeah.
Sometimes it's a pain in the Apollo. And you have in Europe the one.
So let me tell you, for you to understand, this is the hub of the Apollo, and when you deliver the needle, which is or the stuff that you use to enter the little micro wire, there is always a space in between the tip of the needle and the entry of the hub, and the micro wire is always getting inside.
Yeah.
Yeah.
You can use, the green peel off from the scepter catheter, and it can get all the way there. They can help you instead of the metal, the metal thing.
I'm sure he will find a way to get in. Huh? But all those little tricks, there is no possibility to get a perfect fitting between the wire and the hub.
Yeah, he got it.
Is a concern. Yeah, he got it.
So is this the hybrid wire? What wire?
It's fantastic, the hybrid.
Is that what he?
Yeah. So he has been using an Angiocat color green, which means that it's something like an 18. Okay. So now the wire in the Apollo.
Jacques, I have a question. This patient waited 6 months from the initial rupture. Why you wait 6 months? Because
Why not? Let the hematoma resolve, the patient improve.
Yeah.
It's not an aneurysm.
The patient got a recovery, the patient went through physiotherapy, at least if we do something wrong and if we injure the patient, we know that we are responsible of that. The good point is to not wait, do everything at the time of the bleeding, and now the natural history of the bleeding is responsible of the disaster. Here we take our responsibility and we are responsible of a potential disaster, okay? So as you can see, the tip of the Apollo has been measured, and 1.5 centimeter long is a little bit too long compared to the size of the microcatheter. I know.
You have in Europe the 1.5 centimeter, is a 1.5 centimeter detachable tip, right?
Yeah.
You have 3 and 5.
3, 5, 1.5, 3, 5. So now he's doing a selective injection to try to understand better the nidus and also to have a clear view of the venous drainage, which was, this is one of the key points. You don't have any superimposition with the other branch. And when you inject this, you have a very nice view of the venous drainage. So the venous drainage that was looking a little bit tricky doesn't seem to be that tricky.
Not so bad.
Yeah, not so bad. Not so bad. So now you have a clear view of the venous drainage, you have a potential access from the artery, you still have some segment of the vessel that you can continue to catheterize and get closer to the nidus.
You don't worry about that.
But at least, on this direction, you have a very nice view of the output of the venous drainage. There is a segmentation of the straight sinus, as it happens very frequently. So sometimes you get in the good channel, sometimes you get in the wrong channel.
Jack, the 4D of Siemens help you a lot in looking at the vein, because you can get rid of the arterial side.
Mm-hmm. So you mean you navigate on the MR?
No, nothing more with the Dynacity.
4D Dyna.
With the Dynacity.
Okay. And you have a better view than this selective injection?
Actually, it helps. It really helps because you can phase it. You can look at the arterial side. You can wait a little bit, look at the venous side. It adds another dimension which we're not used to in the past.
Okay, so you have to understand that, doing such a case, which is not that easy, in live condition, there is no transmission of some stupid question coming from the audience. For the time being, there is not that much stupid question, nor from the faculty, nor from the audience. But you have to be concentrated, and you have to understand that you are sitting in a very comfortable way, in a nice room, looking at the screen, and forgetting that a case is on the way to be treated. It's not an easy case. We could have chosen to show you another flow diverter in another stupid, straightforward or loopy vessel, which has absolutely no interest. Here we show you something that is not that easy, but we do it in conscious, we do it gently, we do it safely, we do it as much as we can, and the only obligation we have is to do and to try. We are not obliged to succeed. So this is, something that you have to keep in mind. And even if we don't succeed, it's not a problem. At least you will see how difficult sometimes it is to treat those AVM. It's reality. The big difference between looking at slides and looking at reality is exactly this. You are confronted with the difficulty. You are not just looking at a picture after a success which took 5 hours and after many failures. So keep in mind that this is extremely important for everybody to understand the situation. I'm sure that everybody is comfortable with the treatment of brain AVM. I'm sure that everybody is comfortable with double arterial and venous approach. And I'm sure that everybody will think that this is a piece of cake. But if I am asking you to move to the angio suite, it's a different song. We have to be clear between you and us. We show you things that are not really easy sometimes. It's also part of the course to spread the message, understanding that we are not obliged to succeed. The success of the course is not the success of the case, is the demonstration of a strategy, is a demonstration of the capacity you have to treat the patient, and that's it. So they are losing quite a bit of time because the big concern, again, is to deliver the wire in the hub of the microcatheter. So for some reason, it's a problem. Finally, they succeeded doing the same as what they did before. It's good to be silent sometimes. It's good to stop speaking. It's good to see what's happening, and it's good to think that you should be at the tip of the catheter trying to do it. And it makes a big difference. A little bit of silence and concentration is good. Thank you. So he's switching from a 008 to a 007. Okay, let's try to answer the question. What do you think about combining? I don't understand the question.
Combined treatment.
About combine?
Treatment of AVM.
Combine with what?
I guess they're asking pre-embolization and then resection.
Pre-embolization
Well, I
and
don't know.
resection.
This is what they mean by that.
Maybe,
Could be,
okay.
yeah.
Why not? If we don't succeed to get a complete occlusion of the AVM, there is no question that the patient will go to surgery. The second there is the course is already done. The damage is done after the bleeding, so I don't think, surgically speaking, it's a big concern. We totally agree on that. Why do not stereotactic radiosurgery? This is a very simple, it's a good question, but it's a simple answer. In a patient who got a bleeding like that, immediately pause, I think it's better to offer the patient a radical treatment. Either we succeed by endovascular or the patient goes to surgery, but radiosurgery is not our first choice. What do you think?
And those that have bled in the past, I agree with you. And this one looks ugly, and he's had a big bleeding. I think either resection or obliteration by embolization. Stereotactic for non-bleeding AVM or one that hasn't bled, this is a good one. It's small, it's in temporal lobe.
Yeah, but to us, radiosurgery is safe for conditions where you cannot fix the problem. Yeah. This patient already has a homonymous hemanopsia. So the biggest risk of the surgery would be a homonymous hemanopsia. I think that this is ideal in present era with both transarterial and transvenous, so radiosurgery would not be a consideration.
Now, we just use radiosurgery for this type of case if the patient cannot be treated transarterial or endovascular.
Or surgical.
Or surgical, of course, since it was an AVM that bled. But I agree, if this has not bled, it's a decent option. I mean, it can be done in several different ways too, with good success. Now, just to expand really quickly, like what Alex said a little bit earlier today, there has been some case reports, or actually case series, with acute treatment, acute embolization for the AVMs after a rupture with some good results. But of course, those are case series. But the main question is this: considering that the patient has no intranidal aneurysm that is responsible for the bleed, what is the ideal time to wait? Because the AVM rupture risk, even when it's smaller than an aneurysm, is higher in the first year, right? So probably the sooner the hemorrhage, this chance potentially is higher. So how long would is there like an ideal timing to bring this patient back and repeating the angiogram and planning the treatment for all the panelists too?
Look, after more than 30 years of doing this business, the rebleed rate in AVMs, even if they have some intranet, is very low. 1, 2. I think it's extremely important to permit the patient recover. I have had so many cases that a patient has a thalamic AVM, bleeds, is hemiplegic, surgeon takes it out, fantastic result. Patient never recover. Almost all the patients that I've seen, I think the colleagues too, with a thalamic bleed, almost all recover. If not perfect, almost all recover. So you're not giving the right treatment. So you're always measuring the risk of what you're doing to the risk of the natural history. Right. You are going to treat it exactly when the hematoma is resolved, when the patient is plateauing recovery, then we intervene. That's my opinion.
I think one of the things that can guide you, it's imaging, right? So you do an MRI at 3 months, the hematoma is completely absorbed and all that.
Yep. What if the patient is still...
Sorry, a little bit of information from the front. He's changing the microcatheter because there is something with the Apollo, so he's changing the micro.
Correct.
Okay, continue.
I think the repeat MRI will help you seeing if the hematoma is fully absorbed. The other things is, I think you really need to stratify your timing according to the risk of the AVM, right? So AVM has bled, that's a big risk factor according to the New York Columbia study. The deep location, the deep venous drainage, single venous drainage, so you have to adequate your situation because I think you're right. The bulk of the hemorrhage is earlier, but not for all AVMs, including the ones that bled. So I think if there are a lot of risk factors for rebleeding, you do a little earlier, and imaging can guide you.
Yeah, but don't forget, if the patient is improving neurologically, continues improving, you're giving a chance to that patient to get the best possible outcome. And
so we have very talented neurosurgeon in the room, so who is thinking about doing directly surgery on this case?
I do.
You do?
This case is in Japan, we usually embolize, and after that, we do the hematoma evacuation as well as AVM removal in one time.
So it means that even if you think that you are allowed or you can do the treatment completely by endovascular, you go for surgery. This is your first choice.
Yes.
Because of what? Because of the past history, because of the location, because of both?
Yes, this is a temporal hematoma mainly. So operation is not so easy. This is located deep, but we have this patient a very big hematoma. So we have a very big operation field. So this surgery is not so difficult.
No, it sounds logical, and we have that discussion too.
The difference between radiosurgery and embolization is that this is a tricky case. I think it has to be performed in very experimental and very challenging case. You have to perform to do that. But when you do radiosurgery, I think they don't have to perform to do that, They don't have to perform, they just make the target. If there is some radiosurgeon you have to tell to me, but they don't have to perform, and they will do something quite safe as well, quite easy to reproduce. So I don't know where is the battle now, but in the meeting with radiosurgeons, I think they are very, very, very aggressive at the moment.
I think it's a very important thing that you said, because what you're talking about is reproducibility of the treatment, right? Like if you do like gamma knife for radiosurgery of any type, probably it's the technique itself, it's very reproducible. When you're doing the vascular embolization like this, and it's open surgical resection for this, it's something that you do require, like for this type of case, someone is fairly talented and really understands what the disease is and how to get there. So that's a very important thing to keep in mind.
Again, stratification is important, right? So if you have a patient that has bled, deep location, deep venous drainage, single venous drainage, you can't afford waiting 2 to 3 years to have AVM obliteration because the rupture risk is too high, right? And with radiosurgery,
I don't know. I don't know how you know that's good, but I don't know. I don't know. There's no level of evidence showing that.
I've done it a little earlier if the hematoma.
There's no trial about that, so not sure.
You know, Raoul, you're a good friend of mine, but I basically think the same as the French team.
No, we have different.
You know, Vincent, what he's saying is to me, it looks something that you don't have any answer. You know, how do you know that?
Well,
There is a myth about this, but nobody knows really.
But when you look at the obliteration time of AVM's post-radiosurgery, right? We know that the obliteration time, with, at least on angiographic obliteration, is
22 months. 22, depends.
About
2 to 3 years.
Depends on the volume and depends on many parameters, but it's small one. It's small one. The nidus, the true nidus is very small here. When you see the selective run,
So
the
let's
vein is big, but
Let's say 24 months. Reasonable?
ask to Alex what is the risk of rebleeding during these 24 months. And ask to Jacques what is the procedural risk. And then you try to combine to make up your mind. If you're an expert hands like Jacques, like his team, I think it's a good choice to make this because they are mastering the subject. But
We would have done exactly the
this choice has to
same.
be tailored depending on the experience of each center, I guess.
No, but the point I'm trying to make is that in patients with brain AVMs that bleed and have a deficit, the deficit is going to get better with time. The worst you can do is what Jack said, is operate that, cure the AVM so it doesn't bleed again, and the patient never recover. That to me is a bad treatment. How long? 6 months? If the patient is getting better, you wait. You do image to see it shrinks down. But if the patient now plateaus, then you treat. I'm not saying 3 years.
That's not what Raoul is saying. That's not this. He's not talking about the timing of the treatment of the AVM. He's saying the latency period of stereotactic radiation for ruptured AVM is somewhat of a risk for somebody who has ruptured because there is a risk of re-rupture. However, for non-ruptured AVM, so small like this, you know, much smaller than 1.5 or 2 centimeters, stereotactic radiation therapy is a good option for places that cannot perform like this.
That's what we said a long time ago. I mean, in the beginning of this conversation. We're talking about this specific case. In similar case, this patient, radiosurgery is not an option to me because if you don't want to embolize or you don't have the ability to do this kind of a treatment, it has a good surgical option and the homonymous hemanopsia is already there. You've got to individualize the case. You can't generalize.
Yeah, we're talking basically the same thing. We're just talking about what's, you know, the least invasive or the least risky for the patient. And, you know, it's very clear. For a case that they're like endovascular or surgical options and has rupture, that should be done. But if that's not the case, the patient has a basal ganglia AVM or something like this that you cannot approach transvenously or transarterially and cannot be opened, you know, gamma knife isn't a good option even for an AVM that had rupture. We have treated a couple of them and they usually do okay.
Jack, going back to this case, the super selective injection that we see in front of us now, could you predict that the transarterial possibility to total obliterate is less than, I mean, to me, there's also a normal artery there. Can you say something to us from your from this injection?
He's talking to Vicente.
Sorry.
He's talking to Vicente. But you know, Alex, this is not, if I was to inject intraarterially, I would get much more distal than this. I would go. Guillermo, waiting is actually a good thing after a hemorrhage from an AVM.
Right.
And
I agree.
This is a case in point. If you look at the vein on the original angiogram, it was kind of irregular and dysplastic. Actually, the vein has gotten better. This is what Jacques talked about. But this vein actually looks different after the hemorrhage than it did when there was an acute hemorrhage.
Well, there was a big hematoma.
Yeah.
Right. No, the AVM always change. When you repeat the AVM, the angiogram, like after like few months, I mean, it always look a little bit different. I mean, you always see a little bit more than you should. And actually, more and more we're seeing cases, the patients that come with like small hemorrhages, small basal ganglia hemorrhages, young patients, you do an angiogram, a lot of times it's normal the first time. You should always repeat his angiogram like after a few months, because it's not uncommon that this patient does have a small AVM there.
Okay, so he has changed the Apollo, and now he's doing the new catheterization. So you still have quite a bit of course of the vessel there.
Polo doesn't have any this.
The marathon also navigates better than the, don't you think? The marathon also navigates better. No? Can you only use glue? Or can you use
While he's doing that, I found the paper that I want to talk about. So it's in Neurology 2006 from staff. It's the Columbia AVM series, 622 patients, okay? So what they say here is that for patients that harbor all the three risk factors I mentioned, again, hemorrhage on presentation, deep location of the AVM, and exclusive deep venous drainage, the annual risk rate for those patients is 34.4%. So again, those are cases that I don't think you can afford not having a treatment that is curative earlier on.
Yeah,
And
not
for
having
the patients that
not
don't
having a
have that, 0.9%. So it goes from 0.9% to almost 35%.
Yes, not having a treatment, but I think having alternative treatment has to be compared. Not no treatment, but alternative treatment. I mean, it's amazing, you know, for flow diversion, we're able to wait years and saying that the aneurysm is not cured, but we still see something, but it is stable, it will never bleed again. What's happened with the radiosurgery when the nidus is shrinking a third, and what is the rate of rebleeding?
That's a very good point. Perhaps
you know?
You could do a randomized clinical trial in this patient population.
Because sometimes maybe it looks a little bit, no, when you see those AVM after radiosurgery, that doesn't look the same, no? It looks slower, that looks with...
Correct me if I'm wrong, the classic teaching for post-radiation AVM is you are only protected once you have complete cure, angiographically. But you're right, I mean, there is no direct comparison.
I don't know. We would need a radiosurgeon expert, I think, in that kind of panel when we speak about this.
It has to be 35% in certain situations.
You don't worry to see that stagnation there from the superselective injection?
This is only due to the fact that he stopped the
imaging at that point there.
No, he stopped the fluoro at the time there was still some dye on it. Yeah, so now what he's doing is trying to have a nice view of the two markers, so you have a clear understanding of where you start and when you stop.
He's going to try to penetrate to the vein from the arterial.
Yeah. You know, the foot of the vein is not that far, so once you get it,
He is.
so maybe we have a chance to get it just simply by the artery.
Now, there's also like a second draining vein, right? Smaller one, posterior.
Yes, as well.
Yeah. Does it change your approach if that's the case, Jacques, or that doesn't concern you?
I'm sorry, I cannot answer because I'm speaking with Laurent at the same time, so.
He's going, there's the DMSO.
So according to the flow, according to the structure of the AVM, we were planning to use a fill 30, 25, I don't know, LV. And now we are going to use the fill 12, LV. Low viscosity.
Viscosity. I don't know.
You see, there is a new hub. You can adapt the hub to all kind of catheter. I mean, the thing which is at the distal, the thing which is at the distal part of the syringe, you can adjust completely the new system to the hub, whatever the catheter you are using.
They have different sizes for different.
No, it's the same. It's a universal adapter, which is very convenient. So whatever the hub of the catheter, it adapts very nicely.
Is from microvention or from?
It's a fill. Fill is from microvention.
No, but the adapter is the adapter from.
Yeah. It comes with a fill. It comes with a fill.
There was the MSO, and now is the field.
So as usual, it's a DMSO. So it has been. So the DMSO was washed, and the fill low viscosity is getting out. For the time being, it's perfectly going in the nidus. We are waiting anxiously the vein, the foot of the vein. We are getting the foot of the vein already. So when the foot of the vein is full, we wait a little bit, and then we continue to inject to reflux from the venous output to the nidus itself. Yeah, something which is too much round like that, probably it's subarachnoid space. It looks like. Yeah, the foot of the vein is not obtained. It was too round, too well circumscribed, like a bubble. So probably there is already escapes of the fill inside the subarachnoid space. But there is another.
You saw another drop down below.
There is another nourishing pedicles from the artery.
For those who were here this morning, we have stopped the transmission when we had reflux inside the feeder. And just after we cut the transmission for the lunch break, then the fill LV was going inside the nidus. So this has been recorded. So Laure, who is a technician in the Bicêtre, probably we need 2 minutes now. So this is, don't be confused, this is the monoplane. You see that Jacques is roughly at the same, on the same situation that he had previously. So we have to switch from the monoplane to the biplane. So in the biplane, they are preparing the last case of the day, but they will stop for a while just for us to see the final injection of the fill late this morning. Okay, so this is the injection of a fill. So disconnect the view which is live from the brain AVM. So I want you to adapt a little bit. So this is the AP and this is the lateral late this morning. This is the penetration of the fill LV on the AP. This is the course of the microcatheter. And we were able to fill the nidus itself and also the foot of the draining vein. So this is what has been recorded this morning. So you see here the recordings. It's roughly 900 pictures that we can record at the same time. So we have been waited 10 minutes before we are able to inject that. With the field, you don't have tantalum powder as a radio-opaque material. It is iodine, so the risk of having unexpected occlusion of the microcatheter is much lower than with the Onyx. With the Onyx, we would not have waited for 10 minutes. So you see here on the lateral view the filling of the foot of the vein. So this is the goal of the treatment. So you have understood that on the first injection, if you remember well, we had a rupture of the nidus. There was no bleeding, of course. It was a rupture of the nidus, which was sealed by the injection of fill. So this is the end of this injection of fill. And this is the last injection of the fill before we are removing the Apollo. So we are sure to fill the foot of the vein. As you can see, this is the AP subtracted, lateral subtracted. This is a collateral vein, so we don't care too much. Laure, can you go to the last, the final angiogram? So this is the final angiogram, the AP, and the lateral. This is the reflux that we had. There is no more early venous drainage. So for the time being, the brain AVM has disappeared. Of course, we'll perform an angiogram in 6 months from now.